Bismillahirrahmanirrahim. Honorable Chairmen, members, fellows, and dear students, Assalamu alaikum. I'm thankful to the organizers to provide me this opportunity, and in next 10 minutes, I would be talking about the Pakistani perspective of medical guidelines regarding the diagnosis, monitoring, and management of rheumatoid arthritis. Now, these guidelines were made at my university by the Department of Medicine at Faisalabad Medical University with collaboration of the Department of Medicine and Rheumatology Department. Now, rheumatoid arthritis is one of the commonest connective tissue disorders involving almost 1% of the population, even in the Indian subcontinent. The patient usually presents with a small joint symmetrical polyarthritis, presenting with tenderness and swelling of the joints, morning stiffness, and in later stage of the disease, there is development of the rheumatoid nodules on the extensor surfaces. There may be extra-articular manifestations and constitutional symptoms like fever, fatigue, and weight loss. Now, the diagnosis of rheumatoid arthritis is done according to the guidelines given by the American College of Rheumatology and EULAR. The target population which needs to be tested is those who present at least involvement of a single joint with clinical synovitis which is not explained by any other disease. The classification criteria of rheumatoid arthritis are basically a score-based algorithm, and scoring is done in different categories. If the score is 6 or more, then there is a definitive diagnosis of rheumatoid arthritis. And what are these criteria? The first is the number, involvement of the number of joints. The greater is the number of joints involved, the higher the score is given. Then it is the serological tests, that is the rheumatoid factor and anti-CCP antibodies. The higher the titer, the greater the score. And then acute phase reactants like ESR and CRP, if they are high, you get a higher score. And then it is the duration of the symptoms, whether it is less than 6 weeks or more than 6 weeks. And we add up the score. If it is 6 or it is more than 6, a definitive diagnosis can be made. Now, talking about the general treatment strategies, non-steroidal anti-inflammatory drugs and COX-2 inhibitors should be used at a minimum effective dose to control the symptoms for the shortest possible time. And same is true for the corticosteroids. They should not be used as a monotherapy, always should be used in conjunction with the conventional DMARDs. It has been seen that at an early stage, when steroids are combined with the conventional DMARDs, it reduces the erosive nature of the disease and radiological progression. However, the corticosteroid should be used at the lowest possible dose and with a rapid taper according to the clinical feasibility once the DMARDs have started to work. Therapy with the DMARDs should be started as soon as the diagnosis of RA is made. We have 3 types of disease-modifying drugs, that is the conventional ones, the biological DMARDs, and the targeted synthetic DMARDs. As you know, the conventional DMARDs are methotrexate, sulfasalazine, hydroxychloroquine, and leflunomide. Among the biological DMARDs, it is the anti-tumor necrotic factors, the drugs acting on the T cells, the B cells, interleukins, and complements. And among the targeted synthetic DMARDs are the JAK inhibitors like baricitinib and tofacitinib. Among them, tofacitinib is available in Pakistan. And among the biologicals, we have etanercept and adalimumab, infliximab, which are available. And the conventional, all of them are available. The treatment should be aimed at reaching a target of sustained remission or low disease activity in every patient. In the initial stages of the disease, the monitoring should be frequent, every 1 to 3 months. If there is no improvement by at most 3 months after start of the treatment, or the target has not been reached by 6 months, the therapy needs to be modified. Now, you measure the disease activity by this disease activity scoring 28, in which it takes into account the number of the joints which are involved, the number of the joints which are tender, ESR, and the global health assessment. And all of them are put into a calculator which gives you a value. If the value is less than 2.6, it means that your patient is in remission. If it is between 2.6 to 5.1, it means that the patient has moderate disease activity. And if it is over 5.1, it means that the patient has high disease activity. Methotrexate, we start with the conventional DMARDs. Among them, methotrexate should be the part of the first treatment strategy. In those patients who are not tolerating methotrexate or have a contraindication to methotrexate, leflunomide or sulfasalazine may be used. Short-term steroid should be considered when initiating or changing a conventional DMARD in different dose regimens, and should be discontinued as rapidly as clinically feasible. Once the DMARDs are starting to work, we start reducing the dose of these disease-modifying agents, steroids. If the treatment of target is not achieved with the first conventional DMARD, then what to do? In the absence of poor prognostic factors, other conventional DMARDs can be added, like you can add sulfasalazine and hydroxychloroquine to methotrexate if there are no poor prognostic markers. Now, what are these poor prognostic markers? It means that if the disease is polyarticular, if the ESR and CRP are very high to start with, if the NTCCP or rheumatoid factor is in a high titer, or if it is an erosive disease radiologically, these are the bad prognostic factors. If these bad prognostic factors are present, then we need to add a biological agent or targeted synthetic DMARD to the conventional DMARD. But a word of caution over here is, before starting these agents, you need to assess for all the risk factors. The common thing is infection, which you have to look for, latent tuberculosis. You have to look for Hep B and Hep C infection, and other infections, if they are present, you have to treat them first, because otherwise you can get a flare of these diseases when you start these biological agents. The biological or target synthetic DMARD should be combined with a conventional DMARD. However, in patients who cannot use a conventional DMARD as co-medication due to their side effects, we can use interleukin-6 pathway inhibitors and target synthetic DMARDs. In some trials have shown that they have some advantages over other biological agents. If a biological DMARD or a target synthetic DMARD has failed treatment with another they should not be combined with each another. However, another agent with a different mode of action can be tried. Now, once the disease is in remission and you have tapered down the steroids and patient remains in sustained remission for 6 to 12 months, one can consider tapering down the dose. The first one which we would taper down is the biological disease-modifying agent. And if we are successful in tapering down the biological DMARDs, then we go for reducing the dose of conventional DMARDs. Mind you, methotrexate is the first to be started and the last to be tapered down. Now, as a take-home message from my talk, rheumatoid arthritis is a treatable disorder as per diagnosis and implementation of correct guidelines. Treatment of rheumatoid arthritis need to be tailored as per patient's physical, mental, and socioeconomic status. There is still a role of triple therapy with conventional DMARDs in RA in those patients who do not have any poor prognostic factors, particularly in the third world countries where cost is the main issue. After application of latest target to treat indices plus rationalization of poor prognostic factors, disease process is better controlled with timely addition of a biological DMARD or targeted synthetic DMARD. It is our recommendation that target synthetic DMARDs may be considered ahead of biological DMARDs as opposed to the European guidelines, because over here the main constraint is economy. The patients are poor, they are non-affording, and a biological agent roughly would cost approximately 1 million per year, whereas a target synthetic DMARD would cost 2 to 3 lakhs per year. So if the patient is not affording, then we can go for the targeted synthetic DMARDs. And if our patient does not have a poor prognostic factor, even we can go for the triple conventional DMARDs. We do not cost that much and have lesser side effects. I'll stop over here. Thank you very much if there are any questions.